9-month-old boy child with fever and acute kidney injury that has come to our hospital nearly 2 months back. So, 9-month-old boy child was a child of a migrant worker from Assam, and as they had a recent travel history from Assam, there is no history of any renal disease in the past, and he has presented with fever and vomiting for last 4 days. The fever was high grade and the vomiting was almost continuous. They have visited a nearby local hospital. There has given some antipyretics and antiemetics. But after the 2 days, the mother has noticed the child has developed rashes all over the body, initially starting from the limbs, then spreading over the trunks, and followed by facial puffiness and both legs swelling. For this, the mother has brought the child to our hospital casualty around 2 p.m. in the afternoon. And at the examination, patient was lethargic, pale and edematous. There is a percurations all over the limb and trunk. Blood pressure was slightly on the higher side, 95%, above the 95%, so on 26 or 94. Patient had tachycardia and tachypneic. Saturation was 94% with a low flow of oxygen. Chest bilateral crepitations were present, abdomen bile distension, and there was no palpable organomegaly. And investigations on the first stage showed anemia, thrombocytopenia, renal failure with creatinine of 2.9, urea of 123, deranged liver functions with a bilirubin of 2.1 with a predominant intralect component of 1.5, mildly elevated liver enzyme 68 and 72. With this, we had a renal diagnosis of acute kidney injury, probably due to any tropical infections like dengue, malaria, lepto, or a enteric fever, or any bacterial infections like urosepsis or a pneumonia that is causing septicemia and DAC, or whether say any primary HUS. So we have sent the relevant investigations, started the child on all the supportive measures, and monitored the urine output. Next day, the patient's general condition was worsening, blood pressure was again high, tachycardia, tachypneic, urine output was only 40 ml over the last 12 to 14 hours. So that day's investigation again showed persisting anemia, thrombocytopenia slightly worsened, renal functions has again worsened, 3.6 creatinine, 168 urea. And other lab investigation, high gynemic metabolic acidosis, urine analysis was 14 and RBCs, chest X-ray diffuse infiltrates were present, normal size kidneys with an increased coronary echogenicity, mild hepatosplenomegaly, IVC was dilated and non-collapsing. So the child was initiated on renal replacement therapy, peritoneal dialysis was started and continuous exchanges were given. So on the third day, it was slightly better after starting of the renal replacement therapy. So we have followed up the pending investigations. Next day, the investigation again had anemia, thrombocytopenia, renal functions were slightly better as we have started him on renal replacement therapy. And the other investigations showed a peripheral serum of schistocytes and persistent thrombocytopenia. LDH was high, Coombs test was negative, D-dimer was mildly elevated. There is a mild coagulopathy of INR 1.3, C-reactive protein was elevated, procalcitonin was slightly high, and the dengue NS1 and IgM came as positive. So this week we had come to a diagnosis of dengue fever with probable thrombotic microangiopathy. Our differential diagnosis were there is any disseminated intravascular coagulation. So we had sent for Adams-T 13 level, C3, C4 and ANA. But next day the child developed seizures, status epilepticus. This was very difficult to control seizures with worsening of GCS. Then hypotension requiring inotropes and intubated. Then sent the child for an CT brain which showed no evidence of any bleed. CSF has been done that day night itself, cells were 5 and 14 of 6 slightly elevated, and the CSF has grown positive for IgM dengue. So our diagnosis was a expanded dengue syndrome with secondary thrombotic microangiopathy. So profile of dengue fever is an asymptomatic dengue, undefined fever, dengue fever, hemorrhagic fever, or a dengue expanded dengue syndrome. Briefly about the mechanism of renal injury in dengue, can be hemodynamic instability and shock, can be because of the direct action of the virus, immune mediated hemodialysis or rhabdomyolysis that is leading, or a secondary TMA. It may be immune mediated complement activation, or because of this endothelial injury of high blood pressure also. Multiple case reports has been reported about dengue associated TMA, but mostly all are in adults, adolescents or adults. Few case reports has been reported in pediatric patients. Only 1 or 2 case report has been reported in infants. So this case is significant due to rarity of thrombotic angiopathy in dengue fever and the atypical presentation of renal involvement. Early recognition and diagnosis of TMA is Immunoprevention is essential to prevent complication. What happened? This patient is around at 8th day. Patient had a profound hypotension, then requiring drops, extensive bleeding. Patient has succumbed to illness by 8th day after admission to our hospital. Thank you, sir.